Hello and welcome to our webinar. Today we'll go over the 2021 E&M Revised Guidelines. My name is Nichole Hunt and I will be your presenter today. After completing this training, you will be able to understand the CPT E&M office or other outpatient service revisions and when these changes will take effect. You'll be able to identify why CPT E&M revisions are needed and the benefits they will provide. You'll also understand how the foundational changes will impact your practice. Evaluation management services are the most frequently billed CPT codes in all of medicine, which affect nearly every medical specialty. The broad classification of E&M services include, among others, the following: office or other outpatient services, hospital inpatient services, prolonged services, preventative medicine services, and care management services. CMS stated in the final rule 2019, page 584, we recognize that many commenters, including the AMA, the RUC, and specialties that participate as members in those committees, have stated intentions of the AMA and the CPT editorial panel to revisit coding for E&M office outpatient services in the immediate future. We note that the 2-year delay in implementation will provide the opportunity for us to respond to the work done by the AMA and the CPT editorial panel, as well as other stakeholders. We will consider any changes that are made to CPT coding for E&M services and the recommendations regarding appropriate valuation of new or revised codes. Effective January 1, 2021, CMS is aligning E&M coding with changes adopted by the American Medical Association and current procedural terminology editorial panel for office outpatient E&M visits, which will retain 5 levels of coding for established patients, reduces the number of levels to 4 for office outpatient E&M visits for new patients, and revises the code definitions. It also revises the times and medical decision-making process for all of the codes and requires performance of history and exam only as medically appropriate. It also allows physicians to choose the E&M level based on either medical decision-making or total time. 1992. With that distinction in mind, let's talk about the status of E&M codes. These codes essentially have not changed since CPT implemented them in 1992. And most E&M codes are still described in the terms of history, exam, and medical decision-making. Physicians have continuously voiced frustration over the unnecessary exams, the documentation needed to comply with the guideline requirements, but these are not supportive of their patient care. This essentially limits their time with the patient. 1995 and 1997 guidelines are out of date in the history and exam. Often they are not reflecting the most clinically necessary information for patient care. What is the goal? Simplify E&M visits and the work required by the physicians by increasing the overall care and treatment the patient will receive. This will also allow for decreasing the administrative burden of documentation, eliminating the need for unnecessary and duplicate documentation in the medical record, and reducing the possibility or risk of audit. The new AMA CPT E&M changes are specific to office or other outpatient services only. Until adopted by other payers, including Medicare, they are specific changes to the CPT manual only. There will be a deletion of 99201. This code will no longer appear in the code book after 2020. The reasoning is based on the fact that both 99201 and 99202 are associated with straightforward medical decision-making. History and physical examination will no longer be parameters for level of service selection. There'll be new guidelines specific to the codes, changes in the component scoring for both new and established patients, changes to the medical decision-making table, and changes to the typical times associated with each E&M code. Medical decision-making includes establishing diagnoses, assessing the status of a condition, and/or selecting a management option. Medical decision-making in the office or other outpatient service code set is defined by 3 elements. 1, the number and complexity of the problems that are addressed during the encounter. 2, the amount and/or complexity of the data to be reviewed and analyzed. 3, the risk of complications, morbidity, and/or mortality of a patient management decisions made at the visit associated with the patient's problem, diagnostic procedure, or treatment. While the physician's work in capturing the patient's pertinent history and performing a relevant physical exam contributes to both the time and the medical decision making, these elements alone should not determine the appropriate code level. The revised code descriptors state a medically appropriate history and/or examination is required. In relation to medical decision-making, the approved revisions did not materially change the three current medical decision-making elements, but they did provide extensive edits to the elements for code selection and revised or created numerous clarifying definitions in the E&M guidelines. For time, the definition of time is minimum time, not typical time, and represents total physician or other qualified healthcare professional time on a date of service. The use of date of service time builds on the movement over the last several years by Medicare to better recognize the work involved in non-face-to-face services like care coordination. These definitions only apply when code selection is based on time and not medical decision-making. When selecting an office visit code based on total time, physicians may also include time spent performing these activities: preparing to see the patient, obtaining and/or reviewing separately obtained history, performing a medically appropriate examination or evaluation, counseling and education with the patient, family, or caregiver, ordering medications, tests, or procedures, referring and communicating with other healthcare professionals, documenting clinical information in an electronic or other health record, independently interpreting results and communicating results to the patient, family, or caregiver, and of course, care coordination. The new time-based E&M thresholds, codes 99202 through 99215, now have time ranges rather than a single threshold time. The CPT editorial panel used the current CMS table of risk as a foundation for designing the revised required elements for medical decision-making. Current CMS contractor audit tools were also consulted to minimize disruption in medical decision-making level criteria. They removed ambiguous terms such as mild and defined previously ambiguous concepts, acute or chronic illness with systemic symptoms. They redefined the data medical decision-making element to move away from simply counting tasks to focusing on tasks that affect the management of the patient. Physicians and qualified healthcare professionals will be able to focus on taking care of their patients rather than performing potentially unnecessary documentation, simply to meet outdated requirements. It will provide appropriate coding and payment pathways based on the clinical scenarios by utilizing total time or medical decision-making as code selection criteria. It will also provide greater clarity in definitions and may lower the risk of potential audit. As promised, CMS is adopting the AMA Relative Value Scale Update Committee's recommended values for office outpatient E&M visit codes for fiscal year 2021 and on, and the new add-on code CPT 99417 for 15 minutes of prolonged service time. CMS has also simplified the payment by using a single add-on code describing the work associated with visits that are part of ongoing comprehensive primary care and/or visits that are part of ongoing care related to a patient's single, serious, or complex chronic condition. The new prolonged service code 99417 represents 15-minute increments. It is used in conjunction with your level 5 new or established patient, and the units will be based on total duration of time, as you see demonstrated in this graph. CMS has also proposed add-on code for HCPCS Level 2 codes. Visit complexity inherent to evaluation and management associated with primary medical care services that serve as the continuing focal point for all needed healthcare services. Add-on code GPC1X will be listed separately in addition to levels 2 through 4 office, outpatient, evaluation, and management visit, new or established. This code is to capture additional resources that primary care practice expends caring for patients beyond the average evaluation and management visit. Our second complexity code is for non-procedural specialty care, GPC0X. Visit complexity inherent to evaluation and management associated with non-procedural specialty care. As you will see, it includes the following specialties. This add-on code will be listed separately in addition to levels 2 through 4, office, outpatient, evaluation, and management visit, new or established. These specialties are included because not all their services include surgical intervention. Let's take a quick knowledge check. A 35-year-old female established patient presents to her primary care physician for follow-up of her stable type 1 diabetes mellitus. The physician performs a medically appropriate history and physical and determines the visit meets a low level of medical decision-making. Please select the right evaluation and management code. The answer is 99213. It requires low-level medical decision-making. According to the new documentation rules, history and physical are no longer required, but only to be performed if medically necessary. Additionally, burden reduction will be seen through the elimination of the requirements for clinicians to re-record elements of the history and physical exam when there is evidence that the information has been reviewed and updated. Physicians must only document that they reviewed and verified information regarding the chief complaint and history that is already recorded by ancillary staff or by the patient. These changes will also simplify the code selection criteria and making them more clinically relevant and intuitive. It will create consistency across payers by adding detail within the CPT E&M guidelines, and it will also align with current documentation guidelines from Medicare and the CPT code set to ensure minimal disruption to practices. On this slide, you'll see that I have compared the old guidelines to the new guidelines. 99214 under the old guidelines states, office or other outpatient visit for the evaluation and management of an established patient, which requires at least 2 of these 3 components: a detailed history, a detailed examination, medical decision-making of moderate complexity, counseling and/or coordination of care with physicians, other qualified healthcare professionals, or agencies are provided consistent with the nature of the problem and the patient's and/or family needs. Usually the presenting problem are of moderate to high severity, typically spending 25 minutes face-to-face time with the patient and/or family. Now, for the revised 99214 guideline, office or other outpatient visit for the evaluation and management of an established patient. Here's the best part, which requires a medically appropriate history and/or examination and moderate level of medical decision-making. When using time for this code selection, 30 to 39 minutes of total time spent on the date of encounter. All of the information provided in this webinar is believed to be accurate and reliable. However, Coding Concepts assumes no responsibility for any errors. Coding Concepts is providing this information for educational purposes only and not as a replacement for professional judgment and experience. Therefore, any use of this information is at your sole risk, and Coding Concept neither assumes nor is responsible for its use. I would like to thank you all for joining us today. If you should have any further questions, please contact Juliana Stanley at jstanley@azmed.org. Have a good day.